Good evening, everybody, and welcome. Welcome to our collaborative event called Survivorship in Cancer Care. My name is Jenna Sistad, and I am with the Ocean Monmouth Health Alliance. Joining me are partners from RWJ Barnabas Health and our other partners at the SEED program, Cancer Education and Early Detection. Tonight, you will be hearing about lots of aspects of long-term survivorship care for cancer thrivers and survivors. The goal of this presentation really is to welcome this education for primary care service providers, as well as learn advocacy for our thrivers and survivors. So welcome everybody, and thank you for joining us. We're going to get started tonight by just doing a couple of housekeeping items. If you're not speaking, please keep yourself on mute. And we are recording the session for this evening, so please, if you are not interested in being on camera, now would be the time to turn it off. Okay. We have 4 wonderful providers with us this evening that are going to be talking about different topics regarding survivorship in a primary care setting. The first provider is Dr. Casey Baker. Casey Baker is a licensed certified genetic counselor. She currently consults patients in the Leon Hess Cancer Center at Monmouth Medical Center with a special focus on the high-risk breast program and hereditary colon and GI cancers. She received her master's degree in genetic counseling at the University of South Carolina. She previously worked at the Helen F. Graham Center in Newark, Delaware. In Delaware, she lectured at both the University of Delaware and Thomas Jefferson University's genetic counseling program. So without further ado, Casey Baker, I'm going to hand it over to you. Thank you for being with us tonight.
Hi, everyone. Thanks so much for the introduction. My name's Casey. I'm the genetic counselor here at Monmouth. And today I'll just be talking about the role of genetic counseling with cancer survivorship. Let's see. Here's some of my talking points, but I think I just really want to stress that a lot of patients who have been affected by cancer often come to genetics asking the questions, either why did I develop cancer, or people who are unaffected ask, will I develop cancer? But I think they miss the really important questions that touch on survivorship, which are, how do I either prevent an additional cancer from occurring, or how can I have the most personalized treatment as possible? So with that, it's important to think about how common is hereditary cancer in the first place. And if we break it down, sporadic would be your more environmental random cancers, which make up the majority. Familial cancers are somewhere in the middle. We would say that we see clustering of cancers in a family. That could be a combination of environmental, lifestyle, maybe small genetic factors that we can't really test for. And about 10 to 15% of all cancers are hereditary. I think we really need to stress that it really depends on what type of cancer, though. For example, pancreatic and ovarian have a higher rate of it being hereditary, whereas something like lung is far lower. So as a primary care physician or a general doctor, what are some of the things we're looking for when we're first trying to see, could this be hereditary? And some of the key points would be early age of onset in a cancer that should not be young. So of course, we know it can be common to see leukemia at a younger age, but it's not super common to see someone with breast cancer in their 20s or 30s. Also, the red flags would include multiple generations of the same or similar types of cancers, such as breast and ovarian, or uterine and colon in the case of Lynch syndrome. We're also looking at individuals who've had multiple primary cancers, not recurrences, but different tumor sites. And I think one of the big ones that we're starting to look at are individuals with multiple colon adenomas or GI adenomas. We now test all individuals who have had more than 10 lifetime polyps. So that's been a big population pool to capture as well. And we also look for specific ancestry, such as Ashkenazi Jewish ancestry. So when you send them off to a genetic counseling visit, just real quick, what occurs? So someone like me will take a 3-generation family history, at least, sometimes more. We review all personal history, including their relevant screenings, to try to capture some of those things like abnormal pathologies or polyp history. We do run risk models, especially on those who are unaffected. So maybe their family members, such as lifetime risk of developing breast cancer or likelihood of having Lynch syndrome. We also do a risk assessment looking to see what are the possible genes or syndromes that we're looking for. There's also a result disclosure, and with that, we do refer out for different medical management recommendations, screening, surgeries, et cetera. And we work closely with the surgeons and the oncologists to figure out the best treatment plan based on those genetic testing results, as well as follow-up, because we know genetic counseling and testing is constantly evolving with new genes, new panels, and new recommendations. I always like to bring up this slide and remind everyone that we're not looking to see if an individual has a specific gene. Everyone has the BRCA gene, for example. We're mostly just trying to see what did it look like when you were born. So we know that someone who has a hereditary cancer syndrome was born with a faulty or broken gene. So if you are discussing with a patient, just trying to get this concept of we're looking to see if the genes were working properly from birth to see if you have the same cancer protection as everyone else. With genetic testing, and this comes into survivorship as well, we can get 3 different types of results back. A negative result, which means that everything seemed to be normal on that panel. A positive result, which would be the orange result, where the gene is surely scrambled up and not working, and that's associated with the cancer risk. A lot of physicians will often see that a report comes back with a variant of uncertain significance. And this is somewhere in the middle. Think of a single letter typo if you were to message a friend. Usually that friend understands what you're trying to say, but we know that that may be different. This is super important. I've actually recently had a couple of these cases because although the majority of the time these variants are reclassified as benign, a patient who's had a cancer diagnosis who has had a variant of uncertain significance, that later can be potentially reclassified as pathogenic, noting the importance of following up on genetic testing results and just genetic counseling in general, even after a patient's already been tested by a genetics professional, just to make sure that the classification of their results still stands true today. This is just a look at panels. A lot of people often still think of genetic testing as BRCA testing, but we're now testing upwards of 50 genes. And that includes Lynch syndrome, of course, the BRCA genes, but other moderate risk breast cancer genes and genes associated with pancreatic cancer, polyps. We now have renal panels. So the panels are only getting larger. And in most cases, all patients are receiving a full comprehensive panel looking at all different types of cancer risk. And that's simply just because there's so much overlap. And even if a patient has an original specific diagnosis, we really want to capture if there's any additional risks moving forward for that patient. So survivorship, and I think this is probably the key slide for tonight. So for those individuals who are receiving genetic testing and have already been affected by a cancer diagnosis, some of the important reasons why one may want to consider genetics is to inform a surgical decision. So are they doing the correct surgery, whether it's a lumpectomy versus a bilateral mastectomy? If they're doing a colon surgery, did that patient have a history of a lot of adenomas? And could this be a familial polyposis where they may want to consider a full colectomy? So this is super important for the current decisions on surgery. Also targeted chemotherapy options. We know PARP inhibitors are a hot topic with breast and ovarian and metastatic prostate cancer. There's more coming down the pipeline with things like Lynch syndrome. So certainly gives that option for more targeted therapy. Also to prevent additional cancers in the future. So although the cancer survival rate is increasing across the board, someone who has a hereditary cancer syndrome may have an increased risk for an additional cancer in the future that we may want to consider doing a risk-reducing surgery for, or adding on follow-up screening to prevent that second malignancy. It, of course, often tries to give some closure on that golden question, why did I develop cancer? It also helps to integrate people into the proper support groups. So there are specific support groups out there for those who have hereditary cancer syndromes, which just support a lot of the things that I just mentioned and some of the other familial factors that go into sharing genes potentially with children. And of course, you know, it touches on this idea of what about my family members? So just what about my family members? For most, the genes we're testing for, it is autosomal dominant inheritance. So although it does not necessarily affect the necessarily this idea of the patient themselves, part of survivorship is just that emotional future for a patient. And a lot of that goes into what about my children and what about, my daughter's risk for breast cancer. So when we do test an individual, it often becomes a family deal, since autosomal dominance inheritance would mean that all siblings and children have a 50% chance of also being positive. And we do have certain clinics where we can bring in families and work together to identify each individual risk for all family members. So patients who have already had a cancer diagnosis or their relatives, there's lots of options for screening for future cancers. And we work with GI doctors to figure out a proper colonoscopy or endoscopy schedule for patients at high risk. Of course, risk-reducing surgeries with breast, GI, and GYN, and other screening tools such as breast MRIs, mammograms, renal ultrasounds, transvaginal ultrasounds, dermatology follow-up for high risk of melanoma malignancies, prostate screening. And depending on which gene may be floating around in a family that's altered, we do change the variability. So at what age should someone start? That could be as early as age 20, that could be as late as age 40 for a mammogram. When do we consider risk reducing surgery? And if we are getting screened, what is the time interval between screenings? So it all sounds great, but there are considerations. Genetic testing has fallen in price considerably. So luckily, the maximum out of pocket right now is $250, even $250, even for uninsured patients, which is a lot better than it used to be. I would say the biggest psychological impact would be for these patients considering survivorship. So I often see a large stressor that comes with a patient dealing with a current diagnosis and potentially learning about the risk of another cancer. So here they are trying to face what their current management status is or what their plan is, and they're already having a discussion of, oh, well, may I need a different procedure in the future or continue more screenings even after I'm through with this. So that's always a consideration we try to think about with genetics. There's also a lot of loopholes. We haven't discovered all of the genes yet. So some cases and some families, we see a large pattern, but we really don't have an answer yet. There's also false assurance on negative results. So if everything's negative on a family that looks really suspicious, some people think, well, my children can't get cancer, but we know, again, we have not discovered all the genes yet. So we do need to still stress increased surveillance for some of those families. Panels are consistently increasing in size, so always trying to follow patients that may have tested negative previously and getting them back into the clinic to get updated genetic testing. And then, of course, genetic discrimination in that life, long-term care, disability. A lot of these luxury insurance companies can discriminate based on the positive results still. So if you are suspicious of a hereditary cancer syndrome in a current patient currently undergoing treatment, or even someone who has a prior history, the most important thing is first make sure that patient's getting appropriate screening. I can't stress enough how many patients come in for genetic testing but haven't had their regular colonoscopy or their breast imaging. This is super important for any patient that comes through before they just find out if they're at an increased risk. Getting a detailed family history is always important. Getting a history beyond breast cancer is important in a family. So asking about prostate cancer, age of onset, different pathologies, and just be familiar with your local genetics teams, professionals in the area. If you don't know a genetic counselor in the area, other than me or Caitlin Kraft, down in community, you can always go on nsgc.com. That's the National Society of Genetic Counselors. And you can type in find a genetic counselor and type in the zip code, and it will bring up genetic counselors in various specialties, not just cancer, but it will designate whether they're cardio or genetics. So potentially it'll be a resource beyond cancer survivorship. So thanks so much for having me today. And I'll pass it off to Jenna for the next speaker.
Thank you, Casey. So important. My family went through something recently and we did have the genetic testing and so helpful, so thorough. So thank you for the work that you're doing, not only on
Of course.
tonight's presentation, but every day. Moving along to our next presenter, we have Jessica Taft. MD is a triple board certified hematologist, medical oncologist, and internist who founded the Coastal Hematology and Oncology Center. Dr. Taft is currently seeing patients at Coastal Hematology and Oncology Center's offices in Toms River and Forked River. She's also available for consultative services at Community Medical Center, Monmouth Medical Center, Southern Campus, and Monmouth Med. She received her undergraduate and medical degrees at Georgetown University in Washington, D.C. Dr. Taft is fluent in Spanish and welcomes the opportunity to provide multilingual care. Welcome, Dr. Taft. Thank you so much for being with us tonight.
Thanks so much for having me, Jenna. Just gonna share this presentation. So I was asked to speak about follow-up after patients have had cancers and recommendations for primary care doctors and how we can work together to make sure that our patients get the best care. So just a couple things for what we're going to talk about tonight in my portion of this. So who's a survivor and what does post-treatment follow-up mean for these patients? What's the risk of recurrence of cancers? Is there a risk of other primary cancers? And what can you as a primary care doctor do about this? So who is a survivor? So this is actually a term that's used relatively loosely. We would say that anyone is a survivor if you've been diagnosed with a cancer. So there's a large population of survivors, but we tend as oncologists actually not to use the word survivor. So you'll see us using words like no evidence of disease in patients who have been treated and are now just undergoing surveillance, or NED you might see in some of our notes. But overall, there's lots of survivors in the country. So there's greater than 18 million people in the US who would be considered survivors, 32 million worldwide. Of patients who are female, about 44% of the survivors would be considered were treated for breast cancer, 9% for uterine and colorectal, and 8% for thyroid cancer and melanoma. So you can see by far the largest survivorship pool is in breast cancer for females. In men, the largest survivorship pool is certainly prostate cancer. So about 45% of patients who are survivors who are male have been treated for prostate cancer, 10% for colorectal, 8% for melanoma and bladder, and then 5% for non-Hodgkin's lymphoma. Also, the population of the patients who we're treating are certainly changing. So older patients tend to get more cancer. So 2/3 of our patients who are survivors are over the age of 65. That being said, there's also an unfortunate growing population of younger patients who are being diagnosed with cancer. And these may be pediatric patients, but these could also be patients in their 20s and 30s who have a treatable cancer and now are less than 40, but still considered cancer survivors. So that group makes up 6%, and we're actually seeing a significant increase in that population. So what are the needs of these patients? So the concern, and one of the main reasons why I was so happy to participate tonight, is that most of cancer survivors really don't get the appropriate oncologic and primary care follow-up. We see so many times patients saying, oh yeah, I had cancer, 5, 6, 7, 8 years ago, but I haven't seen my oncologist in 4 or 5 years. Or I'm sure as primary care doctors, you see a lot of patients who say, yes, I had cancer, and when you ask who they're following up with, they don't have anybody. And so it's really important that these patients have resources. Why is that so important? Because you need to surveil for recurrence. So not only recurrence of the cancer that they did have, but other primary cancers. And you also want monitoring and intervention for long-term follow-up and effects. And Dr. Megel is going to speak a little bit more about that in a few minutes. So what does post-treatment follow-up really mean for our patients? So we want to prevent recurrent cancers, subsequent primary cancers, and other late effects. We want to screen for cancer spread and recurrence. So a lot of times our patients are really worried about the possibility that their cancer could potentially come back. And one thing that I always try to explain to patients, and that I hope my colleagues do as well, is that after you're treated for a cancer, your cancer care is not done. We're simply moving phases. So there's a treatment phase to your cancer care, and then there's a surveillance phase. And that surveillance phase is included in this survivorship care, but it's really important to differentiate. No, you're not undergoing active treatment. You might not be getting chemotherapy. You might not be getting radiation, but that doesn't mean, we just release you to the wild and say you deal with it on your own. There's a whole host of side effects and long-term sequelae that cancer care and cancer treatment really entails. So we want to assess our patients physically and also psychosocially. So cancer can have lots of different late-stage effects, and these are among the ones that we see the most. We also want to evaluate for other consequences of cancer treatment. So lymphedema, pain, fatigue, psychosocial distress. It actually causes a significant amount of psychosocial distress to our patients after they're done with treatment, because maybe they're used to seeing their oncologist every couple weeks, checking in, having someone kind of take that oversight. And now they feel like there's nobody really watching over them. The other thing that both primary care doctors and oncologists can do is really coordination of care. So sometimes in an oncology patient's trajectory, they might have 4 or 5 doctors. You could easily have a radiation oncologist, a primary care doctor, a surgical oncologist, and a medical oncologist, along with maybe 2 or 3 different types of subspecialists, like say neurology or orthopedics or something like that. And there needs to be someone who coordinates that care, who says, okay, you're done with this treatment phase. This is what we need to do. These are the people that you need to see, and kind of put forward an agenda for the patients. So what are we doing with regard to risk of recurrence? So there's two different types of recurrence, actually. So there's local regional recurrence. So this is a patient who had breast cancer, say in their left breast, and 2 or 3 years later, you're finding a second cancer in that left breast. And that likely is recurrence of that same cancer. The other thing that we're doing surveillance for is something called distant recurrence. So this is the patient who has colon cancer, who had a history of colon cancer, who now was found to have something in the liver. And you biopsy that something in the liver, and that's recurrent colon cancer. So this is when disease becomes metastatic, and oftentimes, unfortunately, when it becomes treatable but uncurable. So these are the things that we want to watch for, because if disease is to recur, we want to make sure that we're catching it early. We don't want to catch disease late, and that's why it's really important that patients undergo routine surveillance, because there's been lots of studies and many different cancers to get these intervals and to get the data to show us when it's appropriate to do these tests. There's also lots of different ways that we can do surveillance. So imaging is one of the main ways. And I highlight an important part about breast cancer patients, because a lot of patients have anxiety about this. So just to remind everybody, patients who have had a lumpectomy, they still need their routine mammographies. We're going to be ordering them as diagnostic mammographies, not screening mammographies, now that you've had a prior cancer. And the way that I really like to explain this difference to patients is that it means that a radiologist is in the house. So if they find an abnormality on their imaging, they're not sending you home, calling you from home, saying, oh, we found something, you're sitting at home really anxious. You're going to get the imaging that you need when the doctor is there and when you're there, so that you're not home waiting anxious. The other thing that's important to notice is that patients who have had bilateral mastectomies don't actually get additional mammographies or imaging for local recurrence. So this is actually a point that a lot of patients are really uncomfortable with, because they're so focused on their cancer care. And people really want to be aggressive with finding recurrence. And suddenly we're saying, whoa, wait, you don't need to go for additional imaging. So it's important that patients remember that if you've had a mastectomy, there's really no breast tissue to do a mammography on. So in their mind, they often think, oh, I need these tests, I need these tests. But we have to remember that we've taken a preemptive step to remove that breast tissue, and there's not actually anything to do imaging of. The other thing to sometimes talk to patients about is that even though in many cancers there are roles for routine surveillance with imaging, like CAT scans, in many, there are not. And sometimes beyond 5 or 6 years, there's not really a role for imaging. That being said, it doesn't mean that after 4 or 5 years, your cancer care with your oncologist is done, because we still have to take symptoms and new complaints really seriously. And we look at them sometimes with a different light, because we're always suspicious about potential for recurrence. So just because, you have a back pain, yes, it could be a regular back pain, but if you have a history of breast cancer, it could also be recurrent disease. And so that's when you do warrant imaging, whereas otherwise you might say, let's take 6 or 8 weeks before we do imaging, and then 6 or 8 weeks of physical therapy before we really move forward. So one of the important reasons to see your oncologist is to be aggressive with these types of things. There's also labs that we can use for detection. So there are cancer markers, which are essentially blood tests that are levels that some cancers secrete. So for breast cancer, we can look at something called CA2729 or CA15-3. For GI cancer, CA19-9 or CEA. For gynecologic cancer, CA125. for disease in the liver, often AFP, and for prostate cancer, PSA. Now, it's important to note that these are not meant to be screening tests, and they're not indicated in every single patient. But in particular, patients who have had distant disease or metastatic disease, we sometimes use these to look for signs of recurrence. One of the other things that we're now using, which is a great development, is blood work to look for circulating tumor DNA. So for example, in my colon cancer patients, I'm now ordering a test called Guardant Reveal on patients post-surgery, which is supposed to detect circulating cancer DNA sooner than a CEA or sooner than potentially even imaging. And the goal here is to detect recurrence early so that you can start treatment or do whatever intervention is appropriate before you really have a significant burden of disease. And then the last way that we look for recurrence of disease is by diagnostic testing. So patients with colon cancer who have had resection, they need a repeat colonoscopy after 1 year. Patients who have had, say, esophageal cancer, they need repeat endoscopies. Patients who have undergone surgery are at high risk for esophageal cancer, at high risk for strictures. So frequent endoscopies are really important in this population. Also, we want to screen for subsequent primary cancers. So what was their prior treatment? Some prior treatments do increase risk of subsequent cancers. Also, what were the lifestyle habits that potentially led to the primary cancer in the first place? Were the patients heavy smokers or were they obese? If you're a heavy smoker and say you had lung cancer, you're going to be at risk for several other cancers, say bladder cancer also. So these are going to be things that you just want to educate your patient about, because if they have symptoms, you want to know about it early. Also, like Casey spoke about, genetic factors. So if you were diagnosed with a genetic alteration or something genetic, you want to make sure that you're getting appropriate screening for a second primary cancer, even if you had something that's unrelated. And then also HPV. So you're at risk for several different cancers with these. Also, what are your chemo-related cancers? So you have to be thinking about chemo-related leukemias. So a patient was treated for, say, lymphoma or 2 or 3 years ago, and now they're suddenly having pancytopenia, they're having low blood counts. You need to be thinking about this as a possibility. The other thing to be thinking about is a lot of our patients who are now 60, 70, 80, if they had cancer, say when they were younger, in their 20s or even younger than 20, some of these cancers were treated with whole chest radiation or sometimes even whole body radiation, and that's going to increase the risk of other cancers later on. So this is most common with patients with a history of lymphomas, ALL, or even astrocytomas. And what we see down the line is increased risk of breast cancer and thyroid cancer. So we really need to be aggressive in screening for these in patients who have undergone these treatments. And then what can you do as a primary care doctor? So the biggest thing that you can do is plug your patient into oncology. So yes, your cancer might have been a long time ago, but that doesn't mean that it's irrelevant. You want to just get your patient back to the oncologist, and ideally if you can ask them to get their records, that's very helpful. Also, you also want to be thinking about long-term toxicity, so cardiac issues, neurologic issues, hearing loss, infectious issues, bone health. So for example, aromatase inhibitors, which we give for breast cancer, can cause significant amounts of osteopenia. So we want to be getting routine DEXAs, and also psychosocial issues. So the biggest thing that we want you to do is to call us and to plug patients in, and we're here to help. And here's my contact information. And I just ask that everybody, give us a heads up and know that we're here for you if you have any questions.
Thank you, Dr. Taft. Keep that up for just another minute while I move along to the next presenter. So if folks want to write down your info, they have the opportunity to do that. Okay, next up, we're going to hear from Dr. Trishala Megal. She's a board-certified medical oncologist and hematologist, currently seeing patients at Monmouth Hematology Oncology Associates located in West Long Branch and Lakewood. She's affiliated with Community Medical Center, Monmouth Medical Center, and Monmouth Med Southern Campus.
That's my daughter.
At RWJ Barnabas Health, she provides care to patients with all stages of breast cancer, gynecological cancers, and in addition to clinical care, she also conducts clinical trials with Rutgers Cancer Institute of New Jersey. Dr. Megal holds a special place in my heart because she is also my mother's oncologist, and we love her dearly. We appreciate all she does for our mother and our family. So thank you, Dr. Megal. Welcome. We appreciate you being here with us and helping us set this up tonight.
Thank you so much. It's a pleasure. Thank you for inviting me, and it's a pleasure to take care of your mom. And it's great to know her. We have a very special relationship. So I'm going to share my screen. Let me find my screen. Okay, can you see? Right? Yeah. Okay, good. So that was an excellent talk. Dr. Taff already started. Everyone can see my screen?
Yes, we can see it. Thank you.
All right, thanks. So, I'm going to talk a little bit about the long-term side effects of cancer therapy and medication management. Especially, why is all this essential? Is because cancer death rates are declining. The incidence is also declining, but not to the same rate as the death rates. And we have improved cancer care. People are living longer, so we have to make sure that they are able to get all the care that they need after their cancer diagnosis. There are estimated 22 million cancer survivors by 2030. So we have to all be prepared to be able to take care of these cancer survivors, and it's an impossible task as an oncologist. So we really need a good partnership between the primary care and the oncology teams to make sure that we have optimal outcomes. Most of these, the cancer survivors, at least 1 in 4 report a decreased quality due to physical problems, and 1 in 10 due to emotional problems after the cancer diagnosis. And there are 2 types of long-term effects. There are long-term effects and there are late effects. Now, the long-term effects are any persistent side effects from the chemotherapy or from the complications of the cancer therapy. And then late effects are the effects that are absent at the time after the completion of active treatment, but appear months or years later. And these can either be treatment related, they can be related to chemotherapy, radiation, immunotherapy, or it can be disease related, which may be due to the physical symptoms, psychological symptoms, financial losses, and they all need to be taken into consideration. And these are some of the long-term side effects like fatigue, cognitive decline, neuropathy, lymphedema, menopausal symptoms, osteoporosis, chronic pain, insomnia, anxiety, depression, and also some of the minor side effects due to the cancer therapies, such as maybe a DVT, anemia, malabsorption, infertility, and work-related losses of financial freedom, which also becomes a huge part of the survivors. Now, one new thing that has come up in cancer therapy is immunotherapy. Immunotherapy has revolutionized how we treat cancers, and for most of the cancers, including breast cancer or kidney cancer, bladder cancer, lung cancer, immunotherapy is going to be a part of the treatment of most of these patients, and that's why it's essential to be aware of the long-term side effects of immunotherapy, as well as what are these long-term effects, how to surveil for them. And these side effects can practically involve any organ system. It can be respiratory, GI, endocrine, neurologic, rheumatologic, hematologic, cardiovascular, and this is something that's it's difficult to monitor. Now, most common side effects that happen due to the immunotherapy are respiratory, GI, and endocrine. And most of these side effects do happen during their treatments at the time when they are closely monitored by their oncologist. But most recently, there was a meta-analysis of 18,000 patients, and it showed that, it showed actually that about of those 18,000 patients, at least 66% of them had immunotherapy related side effect. And the probability of a late onset from the treatment initiation, there was a 57% probability of having this side effect. 35% had an ongoing side effect at 24 months. And 6.9% the toxicity actually started 1 year after their treatment initiation. And this is important. Most recently, I had actually a patient who developed adrenal insufficiency 4 months after stopping her therapy. So at this time, sometimes they are not seen by their oncologist every couple of weeks. It's usually, every couple of months or so. And that's why there are sometimes reasons where some of these toxicities can be overlooked or omitted or just neglected by the oncology team. Now, one of the other side effects that is very, very common, it happens, is cancer-related fatigue. 80% of patients during their chemotherapy experience fatigue, and about 45% experience it during all their active treatments, and 30% in remission. And this is it's a distressing, it's a persistent subjective sense of physical, emotional, and cognitive tiredness that these patients experience, and it's really interferes with their normal functioning. And what do there are several factors that need to be taken into consideration. So timing is very important. If a patient reports fatigue immediately after radiation, I know that it's likely due to the radiation, it's likely radiation induced fatigue. But if that fatigue happens, a couple of years when, the curative treatments are done, there is really no reason for the fatigue, then we always think about recurrence as well. But at the same time, it is important to reassure that fatigue does not always mean recurrence, because I have patients who don't report fatigue just because they are just afraid that it might be a sign of recurrence and just keep it to themselves at time. Now, after that, what are the other things to consider? What is the onset, the pattern, what is the distribution, what are the associated factors? I recently had a patient who, I switched so many aromatase inhibitors for breast cancers, and she kept reporting fatigue. And then it was one visit that her husband came with her and said, she doesn't sleep till 4 a.m. She keeps watching TV. And I was like, oh God, that's what is causing your fatigue, rather than really the aromatase inhibitor by itself. And then I just gave her a strict schedule of sleeping, and she is doing much better without having to make any changes with her aromatase inhibitor. So those are the things that can be overlooked. So there are so many contributing factors to fatigue. It can be pain, it can be sleep, it can be drug interactions at times. We give certain antiemetics during chemotherapy, which may be interacting with some other medications that the patients are on, and that can also cause significant fatigue. Anemia can cause fatigue. Sometimes it's just physical deconditioning or emotional distress. But always, if somebody's on, especially if somebody's on immunotherapy, we do make it a point to check their thyroid hormone status or cortisol levels to make sure that the fatigue is not due to an endocrine disorder. Now, what do we do about this fatigue? I also see this fatigue amongst the common, sort of the maintenance medications that most patients are on now, and such as everolimus or PARP inhibitors, and that is also important to consider when you're considering the treatment for the fatigue. So low-level exercise has really shown to help with fatigue, because some of the fatigue is sometimes caused by inflammatory mediators, and that has, so I always recommend all my patients to consider exercise. Sometimes it's just going through the medications, maybe olanzapine, gabapentin, beta blockers can sometimes cause fatigue without being very obvious. There are other physical, so physical activity is of course important, but yoga or just massage therapy has been shown to be very useful for fatigue. Acupuncture, the bright white light therapy for 30 to 40 minutes in the morning has also shown to stimulate the suprachiasmatic nucleus and has been shown to be helpful. If someone has advanced cancer, sometimes just short-term steroids have shown to be helpful. Also, the other thing to do if you're experiencing this fatigue is to just, prioritize your activities for the day, what you absolutely need to do. Make sure that you're able to prioritize those activities, or you have some sort of aids in terms of, having coverage for meals, or someone is doing your groceries for you. Those sort of things are important. So it's important to set priorities and have realistic expectations due to in terms of managing fatigue, but it's not always easy. In terms of medications, really, there's very little data that any of the medications other than physical activity really helps with the fatigue. There is some data to have shown that some drugs like methylphenidate may be useful. I've personally never used it. It can cause nausea, it can cause headaches, so not a great medication to be on. Now the next is cancer-induced neuropathy. It can be acute or it can be chronic. It's more common with platinum as well as oxaliplatin and taxanes, which is used for breast and colon cancer. So we see it most often in breast and colon cancer patients. Really, there's not much that we can do in terms of prevention. There is some data from due to that cryotherapy may be helpful. What cryotherapy is just to wear stockings and gloves and freeze your hands and feet when you're getting chemotherapy 30 minutes before and 30 minutes during the chemotherapy. There is a trial that's studying cryotherapy along with compression that is just wearing 2 gloves instead of 1, and that has shown to be helpful. So this I have found at least helpful. It's a very low cost intervention, and this is something that I recommend to all my patients. But other than that, what else can help? So we know that gabapentin helps with neuropathy. It just does not have as much data with chemotherapy-induced neuropathy. The other medications, but gabapentin is a good medication in terms of that it's easy to titrate, and sometimes you can just use very low doses to help with the sensitivity. Some other medications are duloxetine that have shown to be helpful, topical menthol, capsaicin. Also, non-pharmacologic methods like exercise, acupuncture, scrambler therapy, which is like a cutaneous nerve stimulation, which is being studied as well. These are some of the methods of alleviating the neuropathy. Now, the chemo brain or brain fog or cognitive impairment, and this happens in 75 to 90% of patients. And it's very, very common. I probably don't have a single patient who has probably not reported this, but the problem is there is not much data available on how to manage these symptoms. We know that it happens based on just the imaging studies. You see that there's a difference in patients who are diagnosed with cancer. And it's not only related to, though the highest percentage of it happens in patients who are receiving chemotherapy, it's also related to radiation, even patients on endocrine blockade, that is someone who's on aromatase inhibitors for breast cancer therapy. Or it's also shown to happen, even patients who are just being diagnosed with cancer. That is, there's a 40% incidence just with the diagnosis of cancer, even not related to their treatments as such, that there can have a little bit of memory problems. The first important thing is validation of these symptoms. It's so often I get the same question from most of my patients that, I feel like I have a brain fog and I don't know, is this correct? Is this true? Is it really there or something wrong with me? Am I just making it up? So validation of the symptoms is the most important because it is very, very common. And then how do we reverse some of the effects? Is it due to sleep, depression, anxiety, fatigue? Those are some of the factors to look into, or what could be causing this sort of brain fog. Routinely, we do try to check the thyroid levels. If there is history of alcohol, then we can maybe, stopping alcohol, B12 levels, and correcting any of the vitamin deficiencies. That has shown to be helpful. In terms of what can help with the fatigue, so again, physical exercise, that's going to be the theme for today's presentation. Physical exercise has really shown to be helpful, relaxation, cognitive rehab, and we'll probably hear about it from the next speaker too. There are some of the pharmacologic interventions, but they're mainly being studied in patients with brain tumors or patients who are receiving radiation, where we give memantine during radiation. That has shown to decrease the brain fog or the cognitive impairment. Or we use special methods during radiation to have hippocampal sparing. That has shown to help. Also, in select patients with brain tumors, donepezil has sometimes shown to help with cognitive impairment. bone health, coming to bone health, it's a huge part of cancer survivorship, because it's very common. Most of patients with breast cancer, especially, they are on aromatase inhibitors, does lower their bone density. Also, prostate cancer patients who are on ADT, that is androgen deprivation therapy, patients who are on steroids for lymphomas can also have an effect on their bone health. And also the very fact that some of these younger patients achieve early menopause causes a decreased bone health. How do we monitor it with a DEXA scan? So for normal patients, we sometimes use the FRAC score to know what is the risk of fractures, and whether they should get bone modifying agents. But in cancer patients especially, it's not really been well validated. So we have to use our judgment in cancer patients when we are trying to decide who should get bone modifying agents. Now, what do we look for? We look for the vitamin D levels. So calcium and vitamin D supplements, very essential. The daily dosing is supposed to be 1200 milligrams. So depending on how much you get in your diet, you have to make sure that you get the 1200 milligrams of calcium and at least 800 international units of vitamin D, if the vitamin D levels are normal. Also, bone modifying agents. Now, most recently, in the past few years, we have started any high-risk breast cancer patient is going to be on bone modifying agents, irrespective of her bone density, especially if their risk of distant recurrence is more than 10%. So we are going to be seeing more and more patients on adjuvant bisphosphonates, and hence the requirement to monitor also the side effects due to the adjuvant bisphosphonates, like maybe monitoring for hypocalcemia or also osteonecrosis. Weight-bearing exercises have been shown to be helpful. Also, smoking cessation, limiting alcohol helps decrease the bone deterioration. Now, coming to menopausal symptoms, hot flashes, dyspareunia, UTI, sexual dysfunction, very essential to address these symptoms in young patients. Also, after their treatments. Usually diet, exercise have shown to help with hot flashes, but otherwise I have had actually good results with Paxil or paroxetine, which is in a low dose. It works really fast and helps with improvement in the hot flashes. But it's important also to consider if patients are on tamoxifen. Tamoxifen interacts with the CYP2D6 pathway and can reduce the efficacy of tamoxifen. So some of the drug interactions have to be taken into account when we are considering these medications, like SSRIs, especially for patients for menopausal symptoms. Oxybutynin, it's a drug that's used for overactive bladder, has also shown to be helpful for treating hot flashes. And sometimes local hormonal therapy may be justified and may be something that we can use for patients, even if they have a history of cancers, depending on what cancer they have had. And it has to just have a good coordination between the GYN and the oncology and the primary care physician before we consider doing this. The next side effect, long-term side effect, that is lymphedema, and it's essential, very essential to address this. Though we are able to, the incidence of lymphedema is very high. It's about 40%. But I see that we are getting better and better at surgery, and especially a de-escalation of therapy to decide who really needs a sentinel node biopsy or who needs axillary surgery, where we can omit radiation, and that has helped actually reduce the risk of lymphedema and the rates of lymphedema. Also, early physical therapy has been very helpful. We do have some equipment or some new techniques in order to monitor for lymphedema. It's called as a SOZO device, which actually measures the extracellular fluid. And that is something that we use in some of our survivors at every visit to see who is at high risk for lymphedema. Also, it's important to rule out recurrence in a new onset lymphedema. Compression sleeve has shown to help and reduce the risk of lymphedema by about 39 to 40%. And then the manual massage also helps by at least 7 to 10% in order to reduce that less risk. And Dr. Taff already spoke about a little bit about the late effects or second primary malignancy. So the second primary malignancy is a malignancy that's happening at least 2 months after the primary care diagnosis. It's an independent malignancy. And there are several factors because these are the same patients who have a genetic predisposition, so they can get a second malignancy. They're the same environmental exposures, and also the cancer treatment that is received can also add on to it. The lifetime risk for developing a second primary malignancy is as high as 33%, and approximately 1 in 4 older adults more than 65 have had a prior history of a cancer. And this is also happens in patients after exposure to chemotherapy like anthracycline, platinum, alkylating agents, and that is something that we continue to monitor. Tamoxifen, there is a risk of uterine cancer with PARP inhibitors. There's a 1% risk of MDS, AML, and that is also one of the reasons why we monitor these patients very carefully. Radiation can cause sarcomas, and also there's a field cancerization effect. So if you have had a head and neck cancer due to smoking, then you're also at a risk for lung cancer or esophageal cancer, and those are the new cancers that need to be monitored as well. Cardiovascular toxicity is mainly seen due to exposure to chemotherapy agents such as anthracyclines or trastuzumab or radiation. And now sometimes, immunotherapy related myocarditis or pericarditis can also happen. The greatest risk is seen approximately about 5 years after the completion of the cancer treatment, and hence some of the factors to take into account is a lipid profile, exercise, diet, smoking cessation, echo, and also enrollment into a cardio-oncology program where some of the high-risk patients receive beta blockers, ACE inhibitors. In terms of managing some of the medications, and most of our patients are going to be, there's more and more trend for maintenance therapies with cancer care. So many of these patients are going to be on some medication or the other, and that's when primary care providers have to be proactive about knowing some of these side effects, such as, with tamoxifen, hot flashes, and aromatase inhibitors. Those are the most common drugs that you'll see, but also the long-term side effects of immunotherapy or PARP inhibitors, that it can cause myelosuppression. It can cause some changes in the creatinine that needs to be watched, or chemotherapy such as Xeloda and Taxol can cause myelosuppression, mouth sores. They have to be aware of this, or interstitial lung disease due to TDXT or TDM1. So these are some of the side effects that primary care physicians should be aware of. Also CDK4/6 inhibitors. Some of my patients have been on it for 5-10 years, and it can cause myelosuppression. So it needs to be taken into consideration. And drug interactions are also important in these patients who are on long-term medications, such as QT prolongation, GI toxicity, any CNS symptoms due to some other drugs that are being prescribed by their primary care physicians. So this all needs to be taken into account, and that's why the coordination with primary care physicians is very essential. What are other things that have shown to improve outcomes in patients with cancer is just the smoking cessation, limited alcohol use, dietary modifications, exercise, yoga, mindfulness, vitamin D supplementation. Really, nothing else has really shown to help improve other than these things. Even if you hear a lot about some medications, I've seen patients talk about glutamine, chondroitin, biotin, lots of different medications, but really there's not enough data to show that it really improves outcomes. Thank you so much.
Dr. Megal, again, thank you so much. Such important information when considering somebody with the diagnosis or who has beaten the diagnosis, always need to continue with long-term care. So thank you. Moving along, next we have Raymond Howard, who holds a doctorate in physical therapy and is the Regional Director of Oncology Rehabilitation at Community Medical Center and Monmouth Medical Center Southern Campus. Prior to his employment as the Regional Director of Oncology Rehabilitation at Community Med and Monmouth Med Southern Campus, he was the Assistant Chief for Physical Therapy in the United States Air Force at Patrick Air Force Base in Florida. So, Raymond Howard, I'm going to turn it over to you, and then I will share my screen as you go through your presentation.
All right, great. Thank you. I mean, I have to excuse myself for feeling a little nasally tonight, but I really enjoyed the presentations. It was like completely awesome to see the stuff that's out there. I learned a lot about, every time I listen to one of these from these experts, I learned so much. My piece that I've been asked to talk about is really cancer-related fatigue, and it's been a passion of mine for, I would say, approximately 15 years now. When we first started looking at some of the problems on the distress thermometers with the as part of the cancer committee, what always came up was the patients feel fatigued. They always feel fatigued, and we really were not doing anything about it. We had a general physical therapy program. We would sometimes receive a referral from the physicians, or we would sometimes speak to a patient and self-referral, try to reach out to the physician for some help. Mainly patients that were participating in our lymphedema program at the time, or patients who were, part of our, we used to have a women's health program. So it's exciting to me to see it's come this far. We actually have worked with Dr. Markowitz at Monmouth South. We've worked with Portia also over at Monmouth South, developing scripts for the providers, which really helps to lay out, and which is really the only slide that I'd asked to be presented tonight, because I think it tells the story of a lot of different things, not only cancer-related fatigue, but some of the other services that we offer. Of course, fatigue we know is part of cancer, and there's a growing number of patients with cancer. My daughter being one of them, a thyroid cancer survivor from 13 years old that she was diagnosed, and still going through blood testing and stuff to watch her antibody counts, now at 20 years old. So, she does feel fatigued for a number of reasons, and sometimes they're really complicated and outside the scope of what we really do. We work closely with the physicians because we know there's a lot of other things just other than physical that may be causing the fatigue for them to experience. We know that things that it may impact their daily living, it may impact their work, even though they've gone through the treatment. Now, how are we going to address these things, and how are we going to help them? A lot of times, patients wonder, what are you going to do for me? You come in, I'm an occupational therapist, I'm a physical therapist, a speech therapist. What we have is we have licensed providers that have a strong interest in helping patients survive cancer. So the first step is they're coming in, we're going to probably do some type of a functional measure, where it might be a 6-minute walk test. It might be a 30-second sit to stand test. It really gives us a baseline that we can communicate back to the physician to try to help them understand how they're getting stronger and encourage them. A lot of the battles that patients are having are psychological. They're afraid. They're overwhelmed, and the last thing they're thinking about is trying to participate in a therapy program 3 times a week for the next 8 weeks. So we do work closely with a physician. We try to, we recommend if there's some help, that maybe some mental health that may be involved, in terms of decreasing stress and anxiety. We try to reach out to the physician for assistance with that, because those are things that are kind of outside of our scope. Lack of energy and interest in doing things such as eating, bathing, dressing, all those things that patients kind of take for granted when they're not sick, and now they're having a lot of trouble doing just the basic ADLs and IADLs. They spend a lot of time in bed, more time sleeping, just feeling exhausted after sleeping. And as I said, inability to work. So we want to try to use our evaluation to try to set those goals, individualize and personalize for the patient to get back to what they love to do. Like I said, the communication with a physician is important. We may see something that maybe doesn't seem right. The patient's not responding as what we would think they should. But the program, really what we want to try to set up to is make sure it's meeting the patient's goals and addressing the problems that they came in for example, strength or conditioning. They may not have the endurance that they have in the past. Looking at the script that I have, I just wanted to kind of go over a few things that Dr. Tav, I know, is very familiar with the script. But when we developed this, we looked at certain diagnoses that would help us provide care for this patient, because it's not just you can come in and the doctor say, I'm tired, and they write physical therapy 3 times a week for 8 weeks, for just being tired. So these are specific ICD-10 codes that really help us to provide that care for the patient so it's reimbursed. Other things might be difficulty walking, abnormalities of their gait. They might be unsteady, as Dr. Mentioned about neuropathy. So some of those things can cause decreased sensation in the legs where they're losing balance, or they might have a higher risk for falling, and we certainly want to prevent that. Some other services that we provide, we have an audiologist at Monmouth South only, Sue Ellen Boyer. I'm sure many of you know. She, if there's any ototoxic hearing loss problems, which that's her specialty that she deals with, she can work with that particular problem in the physician. Dysphagia, we have speech therapists that deal with the dysphagia problems that might come after, chemotherapy, radiation, and so forth, that cause problems with swallowing. Lymphedema has been a really big program for us for over 20 years now. We have 5 specialized therapists that work on not only manual lymph drainage, exercises, wrapping. They do a fantastic job. And Mary Lewentowicz is our prime lymphedema specialist. You may know her. She's fantastic, and she works closely with a physician to treat lymphedema. I don't want to read through all of the symptoms, but basically we're looking at these specific symptoms that someone would have pretty much on an everyday basis for a couple of weeks. So just they have significant fatigue, decreased energy, and just an increased need to rest, which is outside the expected activity level that they have for that particular day. Plus 5 more of the following, certain things such as generalized weakness and limb heaviness. So that could be related to neuropathies or other things, diminished concentration. So we also offer cognitive therapy at Monmouth South through our speech therapist, as well as through our occupational therapist at Community Medical Center. So that is a big problem. I know we're talking about cancer-related fatigue. That's why I thought this form that we developed is really important for everyone to see, that it's just not focused on cancer-related fatigue. We're aware that there's many, many other problems that may be related and causing issues for the patient. So looking at just some of the other particular things that, I'm sorry. Oh, I thought someone was saying something. So we want to make sure that we're addressing the issues that patients are coming in for. So it may be they may have fatigue, they may have swallowing problems, they may have lymphedema, they may have some cognitive problems that are limiting their IADLs. So we're really super excited about our program, that we have this to offer. The only thing that I would say that we're probably could use some more visibility. And I know we work with a physician to try to, I know they do a great job of encouraging patients to come. Sometimes I think the barrier, especially now with COVID, is patients, fear because they're, compromised, and they don't want to come out into a physical setting. So we do offer home programs, although research points to it's not quite as effective as it is a structured in-person, but we have some pretty good success with getting home programs for patients and providing that care, at least trying to get them started until they feel ready to do a formalized program. So that's pretty much all that I have. So are there any questions or anything that I could answer? I appreciate that, but I thank you so much for allowing me to jump on this panel of what I call wow experts. Good stuff.
Thank you, Ray, so much. We appreciate it. And we would love to help you get some more exposure to your program. I have this intake form, but if there's a flyer or something else you want us to share with our coalition members
Sure.
in Monmouth and Ocean County, please feel free to share directly or through Laura.
I sure will. Thank you.
You again. Thank you to all of our presenters for tonight's presentation. I'm going to turn it over to Raven Gates for our Q&A portion.
Thank you.
Hi, everybody. This is Raven Gates. I didn't get to introduce myself before, but I am the marketing and outreach manager for our cancer education early detection program. The short word is SEED. And we help those in Monmouth and Ocean County who are uninsured and underinsured to receive free cancer screenings for breast, cervical, prostate, and colorectal. But I am the facilitator for the questions, and I put in the chat. But since we're here, if anybody has any questions for any of the presenters, feel free to put it in the chat, or if you want to unmute yourself, you'll be able to ask them live right now. All right. Everybody's a little shy. It was a lot of information, but it was a lot of great information. I did have a question. I'll be the one to ask the question if anybody wants to jump in. I know towards, I forgot which presenter was talking about the fatigue as far as with the cancer. Is there any, I would say, natural supplements that someone can take experiencing that outside of if they can't come to your facility, or if someone's dealing with fatigue from, from cancer treatments or anything like that? Is there natural supplements that you recommend that people, because a lot of people are doing their own research through TikTok and TikTok doctors and Instagram doctors, but what is like your educated supplement that you would recommend for someone that is dealing with fatigue, suffering from that?
I mean, I'll defer to Dr. McGall on that. My name is Ray Hauser, physical therapist, but I'm not real familiar with that area, but I'll defer to the doctor.
Yeah, so in terms of natural supplements, so the one that was actually studied was ginseng, and there was some improvement at 8 weeks, but nothing at 4 weeks. So it's a very mixed results. I'm not aware of any natural supplements that actually have shown to have clinical trial data showing improvement in fatigue. What I do know is that there's a 26% placebo effect with treatment of fatigue. So you give any medication, it's probably going to improve. There is going to be a little bit of improvement in the fatigue, just if you call it. So I think that's how some of these supplements work. It's mainly a placebo effect. Jessica, do you have any?
So I agree with you. I'm not a massive fan of supplements just because I think that the data is so limited, but there's certainly a placebo effect. And I get this question a lot, what can I take over the counter? What can I take naturopathic that helps? And one thing that I do always suggest, and that patients do often ask about, is B12. So B12 is often not indicated. Most patients are not B12 deficient, but patients seem to associate B12 with some sort of energy boost. And I kind of say, it's not a guarantee. You may not feel anything different. But if you want to take something, this is something that potentially you can take. It's kind of one of those things that's no harm, no foul. It's a water-soluble vitamin. If you take too much, you pee it out. So there's very limited downside to taking B12. And often if they want to take something, that's something that I offer. But I certainly don't oversell it. But I'm all for the placebo effect.
Yeah.
Awesome. Thank you for that. I have a question in the chat from Evelyn Fuertes, is saying it was really informative. Any suggestions on communicating importance of long-term surveillance with community members that may be hesitant to continue care?
So I personally think that the biggest thing is to just explain it as a different phase of treatment. There's the active phase of treatment where you're actually getting medication, and then there's the surveillance phase of treatment. And I think most of the time when patients don't continue to follow up, it's because they don't really understand the importance of surveillance, because unfortunately clinics are busy and sometimes we don't really take the time to sit down and explain why it's so important to follow up. We say, okay, we're going to check you, but we don't really explain, like, we're going to check you because the likelihood that your cancer could recur in the next, X number of years is 30%. So we don't necessarily give those statistics. We don't want to scare patients, but we also do want compliance. So I think it's just important to explain that, like, cancer care is going to be for many, many years. And often what I tell my patients is this is the beginning of a very long relationship. And it's kind of like dating. We're going to have, points where I see you more. We're going to have points where I see you less. But we're going to be here for each other and we're going to move forward. If for some reason you move away or you go somewhere else, it's important that you find another oncologist, because just because now is when you're getting treated for the cancer doesn't mean that now is the only time that you need to see your oncologist. It's going to be ongoing.
Absolutely. And that's what it's very important to, I think at the first visit I always let all my patients know that how the surveillance is going to be, that at what intervals it's going to be after the completion of the chemotherapy, so that they know what to expect. It's not like they're not sure of what the plan is going to be, or even why we are surveilling, what is the reason for the surveillance, because sometimes it's just like, okay, I'm cancer free, but they don't realize that there is a chance of recurrence, and though even if it's a very small chance, it could be 100% for that patient. And as an oncologist, when I'm seeing my patients, they may not realize, but we are sort of, as oncologists, we are really like hawks. We are always looking for signs and symptoms that are important to us, and we know which patients we want to focus more on, which patients we want to focus less on, because we are they are doing well or they have a low risk cancer. So it's different in different patients, but it's really important. The follow-up is very important, long-term follow-up.
And I actually think that this is the thing that we need everybody's help with the most, because when the patients don't come to us, we have no idea what's going on with them, but they're still going to get normal things. They're still going to get admitted to the hospital. Still going to go see their primary care doctor. And so we need kind of everybody in the community to be our advocates for this.
And compliance is a very big issue, actually. And it's very important to address compliance. I find it the hardest, especially some of the youngest patients need the most help, and really patient advocates in order to make sure that they're compliant with their treatments and they continue their follow-ups for long periods of time. This is very common with, especially with germ cell tumors, young adult males who are lost to follow-up when they should be the ones who are absolutely essential that they follow up.
Yeah, I think Trishal is absolutely right. And one of the biggest concerns is that it's kind of like out of sight, out of mind. Once you're done with your treatment, you want to put it behind you. And so you kind of don't want to see us, even though we really still want to see you.
Mhm. Thank you, ladies, for that information. I think those who we go into the community a lot, so it's good to hear this conversation and having this information. If people are experiencing that hesitation to say, hey, still continue with the oncologist, still check in, even if you're past your treatment, just still having that, in a relationship, you still want to check in and make sure that person's okay every now and again. So that's something that we can reiterate, even as I go out in the community and sharing and talking about that with those that we come in contact with. I see Danielle Duffy has a question. You want to jump in?
Hi, yes, good evening, everyone. I have a question for Dr. Magel. Dr. Magel, I'm currently a caregiver, and I just wanted to know if you could please explain a little bit more detail about the lipids from the cardio slide, if you will, please.
All right. Is this in a particular context or just in general?
Just in general.
So it's important. So the risk of atherosclerosis after cancer treatments, especially after chemotherapy, radiation, is highest, up 5 years after treatment. So I think it's important to make sure that there are lipid panels. So these are the patients who are at highest risk for atherosclerotic heart disease. So their lipid panels are checked. And in terms of, in general, maintaining the cholesterol levels, like a LDL of less than 100 is advisable. Other than that, I would say, I always also refer to cardiologists for their input on this as to how to manage their lipid panels, but that's something that is important. Now, in terms of other cardiotoxicities, say for anthracycline, if they're exposed to chemotherapy that is cardiotoxic, then we usually make sure that we get an echocardiogram done after they've completed their treatment, within 1 year of completion of their treatment, to make sure that their heart function is normal. sometimes there is if patients are at high risk, there are some patients who are, there are some factors that have shown to be high risk, like patients with high blood pressure, or someone who has diabetes, or someone who has a high body mass index. So those are the patients that we work with a cardio-oncologist. We are very lucky to have a cardio-oncology program at Monmouth Medical Center, where we work together, and we initially, right from the beginning, when they're starting their chemotherapy, start them on beta blockers or ACE inhibitors, which have shown to be productive. Now, in this context, we do have a clinical trial that's going to start, which is looking at starting some of these patients who are going to be exposed to cardiotoxic medications and starting them on a statin, which is a lipid lowering medication, right from the beginning of their therapy. So we'll see what the results of that study shows.
Wonderful. Thank you so much. I appreciate the clarification.
I was talking and I was muted. Thank you for that question, Danielle. And thank you, Dr. Megel, for sharing that. Does anyone else have any other questions before I pass it to Jenna? I don't see any questions in the chat. All right, so I think that will conclude our Q&A portion. Thank you, Laura Gallo, and those that have helped to put this together, all the providers that presented on today. This was very informative information that I think we all learned something, just something new today to share and to take with us as we're going out in the community and talking with those that may not know this information, but even just learning and hearing the information was great. Jenna, I'll pass it off to you.
Thank you, Raven. We love partnering with you all. Thank you for the information. As Raven said, Laura Gallo and her team did a phenomenal job at putting this all together. Thank you to our presenters, and thank you to all the attendees who are with us tonight. We plan to do a follow-up email with a short survey, so be on the lookout for that. And we will be sharing this recording for those who have missed it, so be on the lookout for that as well. We hope you have a great night, and thanks everybody. Take good care.
Thank you.
Thank you.
Thank you.